ESPE Connect Online. والESPE عشان يعني الجنرال pediatricians اللي مش عارفين الESPE دي stands for European Society for Pediatric Endocrinology، ودي الحقيقة أهم society بالنسبة لنا في البيدياتريك اندوكراين. وهقول لحضراتكم سريعا كده overview عن الملابسات والأحداث اللي أدت إلى الESPE Connect Online 2020. زي ما حضراتكم عارفين due to the exceptional COVID-19 circumstances, the ESPE Council decided to conduct the ESPE Connect Online 2020 as 9-day event as a replacement of the physical ESPE meeting that was supposed to take place in Liverpool in 2020. And the 9-day event saw over 5,000 pediatric endocrine specialists from 123 countries who came together to share knowledge, best practice, and to discuss the development in the field. More than 30 hours of new scientific and clinically relevant information has been made available for registered viewers, and the registration was totally free. And what's nice is that the registered attendees are able to continue access to the online content, the whole lectures, until November 2021. So you can view and listen to all the lectures over 1 year once you are registered, anytime for 1 year. And the ESPE Connect Online 2020 has been accredited by European Accreditation Council for continuous medical education with 9 European CME hours. So you will take the certificate CME accredited hours as well. And let me open the scene by showing you a summary of the online content over the 9 days from 6th to 14th November 2020. And these were the sessions that were classified through the 9 days in the ESPE Connect Online 2020 sessions. There were hot topic sessions, the how do I sessions, and these were mostly attended because these are very practical sessions, symposia, live Q&A, personal opinion future research, Young Investigator Award, and the yearbook. These were the main sessions throughout the meeting. And what I will do is that I'm going to take you through a Zoom journey through the ESPE Connect Online. Of course, I won't be able to tell you every bit of what happened in the 9 days, but what I tried to do is to focus on the updates and the most important topics that are important to general pediatricians and pediatric endocrinologists. Otherwise, you can check all the lectures once you are registered for 1 year, as I told you. So let's start by the first day. The first day, Friday, 6th November 2020, and this was Thyroid Disorders Day. And it was one of the most attended days over the 9 days. An interesting article was entitled, "One Size Does Not Fit All." And here, the authors set pediatric reference values for TSH that should be personalized according to body mass index and ethnicity. And this article is a very recent one published in European Journal of Endocrinology 2020 this year. They aim to determine TSH reference values in a large cohort of children according to age, sex, BMI, and ethnicity. And this is what they did. They collected data from 2012 till 2014. Healthy children aged 5 to 17 years, thyroid functions were done, and children with known thyroid disease treated with L-thyroxine, anti-thyroid drugs, chronic illness, genetic syndromes, all were excluded from the study. And the thyroid functions were classified according to the BMI and ethnicity. And the result was this very important table. They suggested putting new TSH reference for age, BMI. And as you see in this table, there is a difference between Jewish and non-Jewish. They are another race. They have their own reference range. And for the BMI, there are reference ranges for underweight, overweight, and obese. And this is a very important practical point. You cannot set a TSH for all age groups or any body mass index. It should be classified according to weight and age. And the discussion here was that there are clear differences between ethnic population, Jewish versus non-Jewish. Could there be pituitary thyroid axis TSH receptor isoform T3 differences between ethnic groups? And regarding overweight and obesity, leptin regulation and adaptation of pituitary thyroid axis in relation to obesity is an issue that needs to be investigated. The clinical significance, the reverse causation between obesity and thyroid, which one leads to the other? Obese child will have impaired TSH, or is it hypothyroidism that led to obesity? And finally, this overlap leads to misclassification. Another important lecture by Professor Julian LAGH, which is one of the top figures in the field of pediatric thyroid disease, was hyperthyroidism from prenatal to adolescence. And here she focused on anti-thyroid recommendation in childhood Graves' disease. It was clearly mentioned that methimazole carbimazole dose to start is 0.2 to 1 milligram per kg per day. Starting dose depends upon initial severity. Generally, don't start with very large doses to avoid side effects. Avoid high dose and the cutoff with methimazole 30 milligrams per day, carbimazole 40 milligrams a day, and some side effects are dose dependent, so we should start with a small dose and increase. And once the patient is euthyroid, the dose is reduced by 30 to 50%. Use lower doses without levothyroxine. Avoid block and replace. And if you remember, several years ago, we used to say block and replace is superior on titration. Right now, it's not recommended to use block and replace. And of course, frequent monitoring is very important. And this is a very nice article published in JCM, putting a predictive score for recurrence risk. Predictors of autoimmune hyperthyroidism and relapse on discontinuation of antithyroid. And here you can see in the table on the right side, the scoring system based on ethnicity, age, 34, upper limit of TRAB, thyroid antibodies, duration of antithyroid treatment, all these calculated 0, 1, 2, and 3, and the total score ranges from 0 to 11. And the higher the score, the more the risk of relapse. So this is very useful in order to predict which child will need more treatment for a longer time and who will stop the treatment earlier. Now, the other days, day 2 and 3, diabetes, metabolism, and technology, I'm not going to discuss it because there is a session on ASPED. Nancy is going to focus on the diabetes. So to avoid overlap, I'm going to pass this and go to the day after that. The day after that is the bone and growth day. And there was an interesting lecture on infantile and childhood congenital hypophosphatasia, clinical presentation and differential diagnosis. Hypophosphatasia is an ultra-rare disease due to mutation in the tissue nonspecific alkaline phosphatase. It's diagnosed in children with typical bone features, and the most important is a very low alkaline phosphatase in spite of rachitic manifestations. And the problem is that we are all trained to catch the very high alkaline phosphatase, but we do not look for low alkaline phosphatase. Again, it's very rare, but it's there. And it's diagnosed very late, and the diagnosis is by genetic testing. Now, what happens in HPP or hypophosphatasia? Inactivating mutation in the tissue nonspecific alkaline phosphatase causes deficiency in osteoblast and chondrocyte, inhibiting the conversion of inorganic pyrophosphate to inorganic phosphate, leading to accumulation of inorganic pyrophosphate, which causes all the harm and pathochanges which occur in different tissues. And this inhibits mineralization of extracellular matrix. And finally, it ends by a picture similar to rickets in infancy and childhood, osteomalacia in adults. And the final thing is that, yes, it looks like rickets, but there is a very low alkaline phosphatase. And also there is increase in pyridoxal 5-phosphate. As you see here, it's due to loss of function mutation of alkaline phosphatase gene, and there's a very wide spectrum ranging from the very lethal type up to complete asymptomatic type. So it's according to the degree of mutation in the tissue non-specific alkaline phosphatase. And the low alkaline phosphatase and elevated substrate accumulates in all tissues, resulting in a lot of abnormalities in various tissues, not only the bones. And here you can see that diagnostic delay is common in patients with HPP as initial findings, and this was reported by the HPP Global Registry. Please look for low alkaline phosphatase, not only high. And these are the dental manifestations in children with HPP. As you see, the most characteristic is loss of primary teeth. And here you can see that the tooth is completely lost. It's not decayed, not destroyed. It's lost from its alveolar socket as it is. And this is a very important pathognomonic point in those children. Parents come telling us, my child is losing his teeth or her teeth, and the teeth is not decayed. Think of HPP. Also, craniosynostosis is a very common finding in HPP, and in the chart, you can see plateauing in the skull circumference, reaching microcephalic range with papilledema on fundoscopy. Again, this is another hidden finding in patients with HPP. And these are the typical skeletal X-ray findings in those children. This is the very pathognomonic sign. This is the tongue radiolucent appearance. Rachitic manifestations with radiolucent tongue is very characteristic for HPP. Here you can see the radiolucent tongue, and here there is hypomineralization of the bone, and here you can see the craniosynostosis with increased intracranial tension. In a child presenting with low alkaline phosphatase and rachitic manifestations, think of HPP. So when to suspect HPP? If you have a child with recurrent fractures, deformities, rachitic manifestations, premature loss of teeth, unexplained myopathy, severe respiratory distress, especially in neonates, craniosynostosis, plus low alkaline phosphatase, hypercalcemia, and this is another important point. In rickets, the calcium is either low normal or low. Here, it's high, and hyperphosphatemia. In addition to rachitic findings and bone hypomineralization, put these together and remember HPP. And the good news is that there is therapy for HPP. This is a revolution for HPP patients. Recombinant alkaline phosphatase. It was available 2005, and this is the aspartate alpha. It's a subcutaneous injection every day or every other day with brilliant, impressive results in those children. And this is an article published on enzyme replacement therapy for the life-threatening type of HPP. And what was clearly stated is that aspartate alpha saved the lives of infants with HPP, because it's not only a bone problem, it's a multi-system problem. And you can see here X-rays before and after HPP with very impressive results. Another very important topic in this day was optimizing long-acting growth hormone treatment in pediatric growth hormone deficiency. We all know the short-acting growth hormone, the problem of compliance, giving daily injection. What if we have long-acting growth hormone given once a week? Another revolution in the field of pediatric endocrinology is on the way. And the TransCon lonapeg-somatropin design here was to design a long-acting growth hormone to mimic the daily growth hormone in the tissue distribution, physiological levels, therapeutic effects regarding efficacy, safety, and tolerability. This is what's in the trials going on. And there was a lonapeg-somatropin phase 3 clinical program on the long-acting growth hormone once-weekly therapy in patients with growth hormone deficiency. And here you can see 3 trials on the long-acting growth hormone. The first trial is for 52 weeks. It's called HEIGHT trial. And here they compared long-acting growth hormone to the short-acting daily growth hormone genotropin. The second trial is entitled the FLIGHT trial, and patients were given the long-acting growth hormone in the same dose. The third trial is called the ENLIGHTEN trial, and they recruited the patients from the previous two trials to continue on the long-acting growth hormone. And these were the results of the clinical trial. There was significantly higher height SDS from the baseline in patients on long-acting growth hormone compared to short-acting growth hormone. And even the children who were shifted from the short to the long-acting had a very good growth velocity. So it would be really great to have a very effective growth hormone and given once weekly instead of daily. And this is to show you how the chart went on in the clinical trial, and comparing the adverse events, it was comparable in the short and the long-acting growth hormone. And these are the key features of the pen that was used, the long-acting growth hormone. It can be stored at room temperature. This is very nice. Small needle, single low volume, no wastage of the drug, lifespan at least 4 years, and enables flexible titration, and you can connect it to your Bluetooth and observe what's going on. So this is a real revolution. And so the final thoughts on the long-acting growth hormone. The products have been studied since 1970, long time ago. It may very well present an advancement over the daily growth hormone if it materializes. Several long-acting growth hormone compounds are at various stages of development, with reassuring short-term clinical efficacy and safety in childhood growth hormone deficiency. Our endocrine community still needs to know more about several practice implications in the long-acting growth hormone. And there are still some major issues that need to be more investigated, like the long-term effectiveness, methodology of the dose, monitoring biomarkers, cost effectiveness, and long-term safety. But still, it's a very promising drug if it materializes. The day after that was the PCOS day, polycystic ovary syndrome day. And this is a really challenging topic for pediatric endocrinologists, adult endocrinologists, and even gynecologists. So very high attendance was in this session. How do I diagnose and manage adolescent with PCOS? And the lecturer was one of the top figures in the PCOS in the world. She's a world expert of PCOS. And here she focused on the pathophysiology, diagnosis, and treatment of PCOS in adolescents, the guidelines published in Hormone Research in Pediatrics. So PCOS in adolescent girl is commonly driven by fat excess in the subcutaneous tissue, leading to insulin resistance and hepatovisceral fat excess. And this is the most important pathophysiological mechanism in those girls. The tendency for weight gain in those girls is due to fat excess. It's partially explained by reduced energy expenditure due to reduced BAT, which is the brown adipose tissue. And this is very important as well. If you look at this cartoon, you can see that normally speaking, there is a balance between prenatal weight gain and postnatal weight gain. And here, the Z score of the birth weight and the adolescent BMI are in balance. So what happens in PCOS? Genetic polymorphism, epigenetics, and lifestyle defects like nutrition and lack of exercise lead to a mismatch between prenatal weight gain and postnatal weight gain or adolescence. As you see the curve, there is a great discrepancy in those girls. So there is excess fat in the adipose tissue, and especially hepatovisceral fat. And here you can see that it passes through several stages. In early childhood, there is increased insulin, DHEA-S, low sex hormone binding globulin, hepatokines. Going to the late childhood, there is increased growth, bone maturation, early adrenarche, and pubarche. And then gonadotropin secretion increases with early puberty and menarche, followed in adolescence by hyperandrogenemia, very high androgen, causing hirsutism. Ovulation rate decreases, oligoamenorrhea. And what they proposed is to change the name of PCOS. Instead of saying polycystic ovary syndrome, it's a post-pubertal central obesity syndrome. This is the new proposed name for polycystic ovary syndrome. Of course, the focus of the treatment here is reduction of hepatovisceral fat, healthy lifestyle, and in spite of numerous medications, no approved pharmacological therapy till now in children and adolescents. The most common treatment of adolescents with PCOS is intervention, focusing on treatment of acne, hirsutism, irregular menses, by giving combined oral contraceptive pills. But if you focus on what we said in the pathophysiology, we are just treating the symptoms. It does not address the core pathophysiology of PCOS. So recently, the focus of the treatment is reduction of hepatovisceral fat. And this is the new implications of the treatment. And there is research in progress on GLP-1 agonist to mimic anorexigenic effect of GLP-1, decrease the body weight, improve androgen excess, metabolic parameters, and reproductive function. In such a way, you're treating the cause, you're not treating the symptom. And liraglutide is approved by EMA, FDA, in patients with obesity more than 18 years. Now it's approved. So why not try it in patients with PCOS having common pathophysiology? And another research in progress is combination therapy, spironolactone, pioglitazone, metformin, all together in one tablet. And this tablet is called SPEOMET. Again, this was proposed in several articles published 2016, 17, and 2020. Very recent therapy for PCOS. And a trial compared oral contraceptive pills versus SPEOMET. Two randomized open-label single-center studies compared both parameters. And here you can see that SPEOMET is composed of spironolactone, 50 milligrams a day, pioglitazone, 7.5 milligrams a day, and metformin that we usually give, 850 milligrams a day. And look what they found. Result of longitudinal changes in hepatic fat. You can see that hepatovisceral fat came significantly lower with SPEOMET, which is the combination therapy, compared to giving only oral contraceptive pills. And even the ovulation, the number of ovulation was better in those on SPEOMET compared to oral contraceptive pills. And this was published in the Journal of Endocrinology 2020, a very recent mode of therapy. And the effect of treatment modalities is compared here. Yes, the oral contraceptive pills could have a faster reduction in the androgen, but if you look at the other side of the table, the SPEOMET returns insulin, adiponectin, visceral fat, hepatic fat, more towards the normal. So you are treating pathophysiology rather than the symptoms. And the conclusions from this lecture were, there's an emerging consensus to modify the definition of PCOS, irregular menses, oligomenorrhea, clinical and biochemical androgen excess. In the past, we used to say or, it's and 2 to 8 years after menarche. In treatment, try to focus on reduction of central fat, not the symptoms. The first line therapy, of course, is lifestyle modification. And there are emerging new medications that will have a lot of effect on PCOS, like GLP-1 agonist, which is now approved for adolescents with obesity above 18, and SPEOMET, the combination therapy. It's very promising, but still limited and not yet approved. The day after that was Obesity Day, Simple Obesity Day. And here there was a nice lecture on how do I evaluate a child with obesity. And nicely, the speaker proposed definition of overweight and obesity based on the use of percentiles, weight to length ratio, body mass index, depending on age and sex. And what he tried to do is to highlight that we cannot use the same definition for all age group. If you have an infant in the first 2 years of life, better use weight to length ratio. Above the age of 2 years until adolescence, you can use the BMI. It's more accurate. Again, he put different definitions for obesity and overweight based on the age groups. For babies from 0 to 2 years, more than 85th percentile is at risk of overweight, more than 97th percentile is overweight, more than 99th is obese. The situation is different in children and adolescents. More than 85th is at risk, more than 97th is overweight, and more than 99th is obese. So please take care of the age of the child to define obesity and overweight, and the way you need to define obesity in each age group. Of course, history and physical examination is very important. If normal, evaluate for comorbidities of simple obesity. If abnormal and the child is short, exclude endocrinal disease, CNS injury, hypothalamic obesity. If there is neurodevelopmental abnormalities or dysmorphic features, exclude syndromic obesity. And finally, exclude other drug intake, like, for example, anti-epileptics. Also, the speaker made it clear that dyslipidemia should be screened for in any obese child above the age of 6 years. And prediabetes and type 2 diabetes should be measured and screened as well, even if the child is not complaining, above the age of 6 years as well. And he proposed criteria for defining hypertension based on European Society of Hypertension guidelines. And surprisingly, he recommended screening for hypertension in any obese child above the age of 3, which is very early. And sometimes we find silent hypertension, children who are obese and they have hypertension as well. Also, interestingly, he focused on the NAFLD, non-alcoholic fatty liver disease, being associated with 3 genetic variants. So it does not occur every child, every obese child. There should be genetic susceptibility with specific mutations for that. So the summary of that lecture was diagnosis of overweight and obesity should not be delayed due to potential negative consequence on the child outcome. Weight to length ratio is used in the first 2 years of life. Don't use the BMI. And after that, you can use the BMI. History and physical examination are very important to reach the proper diagnosis and treatment. And don't forget to do lipid profile, blood glucose testing above the age of 6 if the child is obese, and screen for hypertension if the child is above the age of 3 and obese. Now, the day after that was a very heavy day, adrenals and DSD, a very tough subject in pediatric endocrine. And here the speaker, Anne Bachelot, discussed health problem in young people with CAH due to 21-hydroxylase deficiency. And she focused on fertility and reproductive issues in those adolescents. Now, focusing on fertility and reproductive access in CAH women, there is reduced fertility reported in women with CAH. And the factors implicated here are poor hormonal balance, mechanical factors related to surgery, psychological and social factor and sexual factors in those girls. And looking at the gonadotropin axis in CAH women, menstrual irregularities and anovulation are frequent in CAH women, 30 to 70%, which is high. Hirsutism in 20 to 40%. And several factors are increased androgen and progesterone suspected to disturb the reproductive axis in those girls and women. So the menstrual cycle control represents a very important therapeutic target in those patients. And this was recently published in 2019. So this is very recent. Another important and recent finding in girls with CAH is reduced LH pulse frequency and amplitude. This is very important in those women and girls. And the mechanism here was suggested to be excess progesterone and not the excess androgen, as most of us might expect. So suppression of serum progesterone concentration during follicular phase of menstrual cycle should be the major objective in those patients. We need to suppress the progesterone. Now, looking into fertility and pregnancy outcome in CAH women, it was found to be the same in around 91%, conditioned that they are properly treated, you can control the androgen and progesterone. And the mechanical factors related to surgery, first of all, there is a risk of clitoral insensibility and vaginal stenosis. This was an article published 2007, 18, and 16. Another article published in JCM 2010 found that among 92 women with genital surgery, 46 were not happy about the sexual life. Now, recently, in 2016, another article found that among 151 patients with genital surgery, the majority, approaching 94%, which is very high, reported good or excellent outcome result. So nowadays, the new surgical procedures preserve innervation and clitoral sensation, and they have a good outcome compared to the past. And better fertility in CAH women depends on, of course, transition from pediatric to adult care, because sometimes those patients are lost between the pediatric and adult endocrinologists. Optimizing suppression of progesterone, surgical advance in genital surgery, psychological support, and sexual well-being. So finally, the proper management improves fertility outcome in ladies and girls with CAH. What about the males? Fertility and reproductive access in males with CAH. Males with CAH may have impaired gonadal function and infertility as well. And the sperm cryopreservation should be offered because they have a very high risk of infertility, especially males. And the gonadotropin deficiency in these boys is due to adrenal steroid overproduction, hyperandrogenism, and progesterone as well, the same mechanism. Also, a very important missed point, the TART, testicular adrenal rest tumors. And these are in 40% of those boys. It's already present in childhood and increases at puberty and adulthood. They have both adrenal and testicular characteristics, indicating a pluripotent cell type as an origin of TART. And it's responsible for Leydig cell failure and spermatogenesis. And this was published in many important articles, European Journal Endocrinology 2017 and Endocrine Reviews 2019. So please look for TARTs in boys with CAH. And the pathogenesis here is poor hormonal control, and ACTH is the most important factor in development of TART, but other unknown factors could be involved. And the treatment here is simply intensifying glucocorticoid to reduce the tumor size. And surgical resection did not show any improvement in gonadal function in those boys. And this was in 2019. Also, very fast hormone replacement therapy in DSD, given by a pioneer in the DSD, Professor Olaf Hjort from Germany. And this nice table summed up the indication of hormonal therapy in DSD. In a newborn, if you need to achieve virilization before surgical correction, for example, or increase the penile length. In childhood, usually you do not need to give androgen. In adolescence, to induce puberty and maturation. And finally, in adult, to maintain sexual function, endocrine health, and fertility as well. And this table that was published in 2020, a very recent table, proposes the indications of giving hormonal therapy in newborn. It's either whole testicular dysfunction or Leydig cell dysfunction. And for micropenis, you either give testosterone enanthate, intramuscular, you can start by 25 milligrams, increase the dose, or testosterone gel or cream, or dihydrotestosterone gel local, according to the situation. Now, the day after that was puberty and gonads. And there were novel insights on the timing of puberty, the fascinating biology, and some informative insights of puberty. And here, the speaker highlighted imprinted genes which regulate the timing of puberty. It's not as simple as we might think. There are some genes that are mutated in central precocious puberty, MKRN3 paternal, DLK1 paternal, and KCN9 maternal. These are very important genes. And this was the article published in 2020 on the genes incriminated in central precocious puberty with very novel genes, 5 rare mutation in MKRN3, familial central precocious puberty, and 1 rare mutation for sporadic type. And here you can see that secular trends are tending towards early menarche. In the past, if you look at that curve, menarche in Europe used to be at 15.5, very late. Now it dropped to 13.5. In hot countries like us in Africa, it's even low. We see menarche at 10 and even earlier. And there are some secular trends to earlier menarche with increased heritability. And you can see in this table that girls who were born before 1934 had heritability 14% and menarche 15.2 years. Now, if you look to those who were born after 1965, the age of menarche decreased 12.3 and heritability is higher, 21%. Also, there is Mendelian randomization, genetic causal influence. As you see, genetics, faulty nutrition, physical inactivity lead to a high BMI, which leads to early puberty. Again, an article published in 2019 clearly stated that high BMI predisposes to early puberty, as you see, whether in boys or in girls. So there's a worldwide secular trend, change and age of puberty onset, and the age of thyroid decreased 3 months per decade. And this is a very recent article in 2020 that collected data from 1977 until 2013. And the novel insights on the timing of puberty, it's a fascinating biology, rare genetic disorders, secular trend continue based on the BMI, excess animal protein, and physical inactivity. Now, the last day was a miscellaneous day, a collection of endocrinal problem. I chose an important topic, which is important to all of us as general pediatrician. How do I assess cortisol reserve in a child after therapeutic doses of steroids? All of us see children taking very large doses of steroids, and the question is how to tailor that or how to master the adrenal function. A child with rheumatoid arthritis, severe bronchial asthma, systemic lupus, what do we do as pediatrician? Of course, we all know there's a daily circadian rhythm of cortisol, and larger amounts are secreted at periods of stress. All patients on supraphysiological doses of steroid for more than 14 years are at risk of adrenal insufficiency. Please screen those children. And this is the proposed basis published 2019 on how to taper corticosteroids. From the supraphysiological dose, go to the physiological dose, then stop the evening dose, and then the afternoon dose, and then the morning, and then you stop and give a stress schedule. The most important tool is the morning cortisol to screen those children, whether in the blood or saliva. For the blood, the cutoff is more than 500 nanomole per liter or more than 18 micrograms per deciliter. For saliva, more than 20 nanomole per liter, and you consider testing after 3 months of stopping steroids. Only in those who will have low cortisol, you need to do ACTH stimulation test. And take care that the cutoff differs according to the type of assay. And the summary here, iatrogenic adrenal insufficiency is not rare. The risk is related to the type, dose, and duration of steroid. Inform the patient about the risk. Consider testing after 3 months of cessation. Consider low threshold for testing. Use the morning serum cortisol or salivary, and the cutoff is 18 micrograms per deciliter. And this is my final slide. All what you've seen is not my work alone. This is the work of a highly dedicated team, and this is the ESPE Council. I'm really proud to be part of this team who are putting a lot of effort and time to pass this really challenging and critical part of our lives and to keep the ESPE in shape in spite of the challenges. Finally, I wish you all a happy 2021, healthier,